folks. I know. It's fun material and it's kind of exciting, but I guess the good news is it's the holidays, so you get a little time off. Right? It's not like I'm leaving institutions. I'll be around. So what we need to talk about next up, where we left off just before the break, is how this all happens. So is it a little bit more clear to you, like, why in our public health arena we always are broadcasting awareness about diet and blood pressure, right? We're saying, okay, we want to have a healthy, balanced diet. And we want to make sure our blood pressure in our patients is actually under control. And so that's why you're getting blood pressure checks on a regular basis. And, if it's 120 over 80 and then it starts slowly creeping up and it's 130 over 80 and then it's like, 140 over 88. And so that first number is the systolic pressure and that second number is the diastolic pressure. And we're concerned about both. But one of the reasons that you hear a lot of statements about how the diastolic pressure is what we're really worried about, the diastolic pressure is theoretically what the body is seeing when everything is supposed to be relaxed. Right? So if the pressure when your heart is not beating is starting to climb, that means those endothelial cells are getting like no relief. So we just don't want chronic high blood pressure and hypertension in our patients, in you, in mom and dad, right? So one of the natural results of this lecture is always, students are like calling mom and dad, hey, so what is your blood pressure, Dad? I know that you said it was high, and I was like, oh, well, that's too bad. You should take your pills. But now I actually really understand what's going on. And are you taking your meds? Right? So that's what's happening, is too much fat in our diet makes it in our bloodstream. Right? When we have our HDL and our LDL out of whack, and that's why, I got my cholesterol checked. There's always these two numbers. They said that, one was really high, and the other one was where it was supposed to be. I don't know what it means. Well, now you can explain it to Dad, what it means, what those two values are. So if we unravel this and we say, okay, in these patients that have these preclinical lesions that take place, and this says like usually at a young age. So what does that mean? Well, the literature is now describing that some of these lesions can even start forming during grade school years because of our diet. If you're consuming too much of those materials that aren't necessarily for the growth rate, then a lot of them get stored and a lot of them are floating around. And so the younger age data is showing up in grade school age children. And we see this because you can't turn on the news and not see some news story every month about obesity in America, right? And now it's obesity in our children. And so that's probably one of the reasons we're starting to see the preclinical lesions manifesting themselves, not just in middle-aged to elderly, but in a younger population. And we'll get a normal artery, and we'll get a fatty streak or an early form, and it'll kind of start advancing. And as it advances and moves on into a vulnerable or an at-risk, we've got sort of three main outcomes that can happen. I talked about the first one, aneurysm and rupture. So all of these diseases are usually problems of the elderly. You usually don't hear too often about aneurysms happening in young patients, college-age patients, or patients even less than 50 years of age. And the exceptions would be if there's a connective tissue disorder like Marfan syndrome. So Marfan syndrome is a disease where collagen is not manufactured in the correct form or not at all. And because it's an architectural structural protein of the blood vessels, they start kind of expanding under the pressure irregularly. So instead of like a straight aortic tube, this is back to my Gore days, we would see these patients where the normal aorta kind of looks like this. In a Marfan's patient, it was not uncommon to see a patient that had sort of kind of a blown out aorta that was kind of looking something like that. And it's because of this connective tissue disorder, the aorta starts to expand. So other than that, you don't see, in Marfan's patients, you see them at young ages, but you don't see it in young ages, like really below 50 years of age. Okay? And in the elderly, when that weakens and it's pressurized, it can rupture and blow out. The other thing that can happen, if you think back to that histology before the break, and I'll back it up, we're talking about this small little lumen that's about a 65% stenosis. This narrows, and this can actually clot off. And this can actually occlude by thrombus. Right? So the blood slows down in that area and blocks it off and shuts down blood flow. Or thirdly, is it narrows to a point of like 99% closed. It's called clinical stenosis. And it shuts down and blood doesn't happen. And we see these two situations most commonly in ischemic heart disease, but we do see all three contributing to ischemic heart disease, which is what we're going to talk about next. But before we go there, I want to show you some therapies. So this is percutaneous intervention. This means that it's minimally invasive. Oh, wait. Oh, I think I turned down the volume. Yeah.
Percutaneous coronary intervention, also known as coronary angioplasty, opens narrowed coronary arteries. A small, hollow tube called a catheter is inserted into an artery in the groin or arm and threaded to the affected artery. A thin, flexible metal wire is then advanced through this tube and past the site of blockage in the artery. A second, smaller catheter is then inserted over the wire and threaded to the same artery. When it reaches the narrowed area, a small balloon on its tip is inflated to reopen the artery and flatten the blockage into the artery wall, while at the same time stretching the artery open to increase blood flow to the heart. Both catheters and the wire are then withdrawn. About 70 to 90% of coronary angioplasty includes placement of a stent, a wire mesh tube that holds open weakened arteries. The stent may prevent re-narrowing after an artery is widened, and it stays in place permanently as the blood vessel lining heals over it.
Okay? Is that helpful? Now, when we think about these stents,
Percutaneous coronary...
sometimes the stents now that we leave behind, we've gotten more sophisticated because the narrator said that the endothelial lining heals, right? Well, it doesn't really heal well. And so a lot of times it heals aggressively and it re-narrows, or what we call restenosis. So in-stent restenosis is a monster problem. And the in-stent restenosis rates are really, really bad at about 5 years after a stent placement. So if you have a family member that's had a stent placed, coronary stent, in one of the vessels of the heart, it's most common in the next 5 to 10 years they're going to have it redone. But the good news is you don't open the chest to do this anymore. You just fish it up from a peripheral vessel. Now, the other thing that we can do is we've impregnated these stents with anti-proliferative agents. And those anti-proliferative agents are coating the metal stent. And one of the drugs of choice is called Paclitaxel. So if you see these drug-eluting stents, DESs, drug-eluting stents, that have an anti-proliferative drug impregnated into the metal that it releases slowly over time. What it's trying to do is keeping those smooth muscle cells from proliferating mitotically and narrowing the lumen again. Unfortunately, the in-stent restenosis rate of drug-eluting stents, now that we've had them out 5 years, is not that much better than the bare metal stents. Okay? Question? So you do an angio. The question is, how do you know what vessel needs the therapy? So what they do is, if a patient, let's say, has chest pain, okay, we're going to get to angina here in a second. They go in and they get an angiogram or a picture of the heart. And I'm going to show you this video right here. They shoot a contrast agent into the heart, and that contrast agent shows up under fluoroscopy. There's no audio on this one. You see that? The physician is injecting here, and you can see that this is the wire, so you know they're all the way down here. This is a balloon. Right between those two markers is a balloon. You're going to get it in place where the lesion was, inflate the balloon. Right here it's being inflated, and then deflate it. Now inject it. Now look at it, open it all the way up. So that's how you know where it is, because you inject dye in here. It's called radiopaque dye. It's usually a barium sulfate solution, and it allows you to see the roadmap of where the blockage is. No, usually, a lot of times it's multiple vessels, and so, you know, if it's the coronary vasculature, we know that these atheromas form kind of all over the body. And so it could be the right coronary, the left anterior descending, as well as the circumflex. So that would classically have been a triple bypass. And now it's just 3 stents being placed. And then they're golfing the next morning with a tea time of like 10 a.m. Okay, because they don't have to crack the chest. Okay, so we've kind of moved away from this Holy Grail story I was telling you in the very beginning. Right? But we've been using these new therapies to try to reopen up the vasculature and reperfuse, allow for perfusion to take place again. So it's not a lost cause, all of this disease. But if we continue on with this disease and it's left untreated, it ultimately can progress to what we call ischemic heart disease, which is kind of where we started the whole conversation today. Ischemic heart disease is this imbalance between perfusion and demand. Perfusion is how much blood is going there, and demand is what the metabolic requirement is for that O2. The metabolic requirement for O2 is completely dependent upon how much ATP needs to be made. Right? The heart is an exercising muscle, and it's a long-term exercising muscle. You guys with me? It's not like you say, you know what, I'm going to like sprint out like 25 beats. I'll be good for like the next 2 hours. Okay, you just run all day long, right? It's a marathon. So these are slow oxidative type of fibers that need constant supply of oxygen. So the most common cause of ischemic heart disease, bless you, is atherosclerosis, these atheromas. And I keep using the term so you don't mix it up. Athero, which is the atheroma. You can see the word in there. And this imbalance you can see with the formula, another formula. Cardiac output is also determined by heart rate times ejection fraction. So the ejection fraction is how much blood is ejected out of the heart per heartbeat cycle versus how much is left over in the ventricle. So the heart is not 100% efficient. So the EFs, or the ejection fractions, are usually in the 70%. So it's about a 70% efficient pump. Okay, so if you had 1,000 mils that were being filling the heart, only 700 mils would be ejected out, and 300 mils would be left over inside the left ventricle. Okay, that would give you your 70% EF value. So if we look at clinical manifestations of ischemic heart disease, abbreviated IHD, we're going to see chest pain, otherwise known as angina pectoris, or as we refer to it as angina. An acute myocardial infarction, otherwise known as a heart attack. A chronic IHD, or chronic ischemic heart disease. And lastly, but not least, sudden cardiac death. Some patients don't survive. Some patients have an ischemic heart episode and they don't actually survive. Now, within chest pain, angina literally translates as a strangling feeling in the chest. And we have sort of three main types. We have stable, which is the most common. Stable is chest pain that is showing up when you exert yourself, like climbing a flight of stairs upstairs to get your reading glasses, and then they get this chest pain. But when they come downstairs, it goes away, they sit in a chair, and they say, oh, it's no big deal. We just have to climb it a little bit slower. So that's stable angina. There's no heart attack that's happening, but there's some chest pain or some arm pain that's happening upon exertion. Prinzmetal angina, also known as variable, this is usually at night while you're resting, and it's associated with vasospasms, vascular spasms of the blood vessels of the heart. Unstable angina is the most concerning. It's also referred to as crescendo, which means crescendo is sort of that terminology, if you guys know how we were doing the back to the music class. Crescendo means what? You get louder with your music, right? And decrescendo means what? Right? You like finish it out nice and soft. So crescendo means that it aggressively increases over the next 3 to 4 days. You have a plaque disruption. It might cause a thrombus lesion to take place. And it worsens over the weekend, for example. Starting on Friday, by Monday morning, it's really, really bad. That's crescendo angina, or unstable. And then you would say, bring in your dad. Okay, this is not good. So the way you might see these types of questions next week is here. What type of angina occurs because of vasospasms of one or more coronary arteries and is often occurring during sleep? Unstable, stable, silent, or Prinzmetal? Prinzmetal. That's what we just talked about. So if we look at chest pain and we progress it to a myocardial infarction, which is referred to as an MI, what ends up happening is the vessel gets blocked, blood flow is not going to the tissue, the exercising tissue, and you get what's referred to as ischemia that leads eventually to necrosis after about 20 minutes of ischemia. So these myocytes can last about 20 minutes. I don't know if you've seen some of these commercials. Down in the valley, they have these commercials. They're pretty clever. And there are these patients, and then they're all like, white hair, and, definitely older people. And they have these placards, and they hold it up, and there's this time. Have you seen this? It's like for Banner Health or something like that. It's like 20 minutes to treatment, 15 minutes to treatment, 9 minutes to treatment. So why do we care about how fast you treat a patient? Well, you want to go to a hospital if you're having chest pain that has a very high, fast treatment rate. Because beyond 20 minutes, you're going to start seeing some myocardial death. And the wavefront, so here's our left circumflex coming around the posterior aspect. Here's our left anterior descending, known as the LAD artery. Here's our blockage right here. And then this dotted line is showing the distal area that isn't being perfused. You can see how it's whited out right here, and here's the blockage. And in that video that we looked at, this is where you would put the wire with the balloon and try to inflate it to reopen. Okay? If you did that within 20 minutes, you'd probably see no infarct at all. Very unlikely. You're going to see something, most likely. But the wavefront moves, and it moves from the endocardium to the epicardium. So here is a cross-section of the tissue. Here's the inside of the endocardium. Here's our obstructed coronary vessel. You can see after 2 hours, into about half of the myocardium, you've got this necrotic zone. By the next day, it's transmural. That means it's all the way through the wall. So if a patient just fights through the pain and goes in the next day, that's like the worst possible outcome. That's why we want to get our patients in quickly when they have chest pain, so you can treat very, very, very same day, very fast. And then you can avoid this transmural infarct. And if you looked at histology of a transmural infarct, you would actually see the wall of the myocardium, right? Let's look at this picture. This isn't histology, this is actually a gross image. But if we looked at this gross image, let me shut this light off. So if we're looking at this picture, we're seeing a cross-sectional view through the heart. And in this picture right here, this is the left ventricle on this side. This is the right ventricle over here. Okay? And you're taking a look at this inner lining right here. This is all damaged myocardium. All of this lighter color, all of the dark is sort of normal in this particular state. And this endocardial edge hasn't moved transmural. So you know in this patient that this infarct was only about maybe a couple hours old, right? If this lesion went all the way through the wall, here's a higher magnification. You can see all of this damaged tissue. It hasn't made it all the way through the wall. You would expect a transmural infarct to have this damage all the way through. If that was a histology picture, you would see an evidence of an area of, wound healing or inflammation that went all the way through the wall. So what's happening on this slide? When we have patients that have an infarct, we can actually pull blood, and you can pull blood a whole lot easier than you can actually explant their heart and take a look at their histology if you're trying to keep them alive. So you pull blood, and you measure different protein levels. You measure troponins, TNI and TNT. You measure creatine kinase, myocardial bound, and then you measure lactase dehydrogenase. When the heart tissue itself starts to break down and die, it releases the troponin. Remember, troponin is a component of the cross-bridge formation that binds calcium. And so as the cross-bridge formation degrades, because the tissue is dying, the troponin gets released into the bloodstream. So you specifically can measure TNI and TNT levels. So TNI and TNT will show up about 2 to 4 hours after an infarct. They peak at 2 days, so 48 hours. And they remain elevated for about 7 to 10 days. So you can kind of determine how old the infarct was. When did it occur? CKMB is an indication that the heart is no longer, that tissue is moving to an alternative fuel source, as is lactate dehydrogenase. So creatine kinase and lactate dehydrogenase are indicative that alternative energy sources other than aerobic respiration are being leveraged because the heart's trying to find ATP and it's not getting blood flow, therefore there's no oxygen available for aerobic respiration. And so you'll see CKMB levels and peak at about 2 to 4 hours after infarct. Show up 2 to 4 hours after infarct, peak a day to 2 days, so 24 to 48, and they're basically declining by 72 hours. And then lactate dehydrogenase follows a similar pathway as CKMB. And again, lactate dehydrogenase is indicative that the heart muscle is trying to use the glycolytic pathway to generate energy. Now, our last example of complications that can arise from an infarct or heart attack are shown here. We can get arrhythmias because we can get abnormal rhythm. We can have dysfunction of the contracting ability. We can have an aneurysm or a rupture of the heart itself. We can actually have mural thrombus or clot that forms within the ventricle. And last but not least is progressive heart failure. So as a patient develops a heart attack, as it heals, if they survive, and that damage is aggressive, full circle, 5 to 10 years from now, post-infarct, they have a weakened left ventricle. Now the heart is going to have to compensate. It's going to have to work harder to compensate for that lost tissue. So it's very common for surviving ischemic heart attack patients with an MI to, in 10 to 20 years down the road, either have a second MI and or develop signs of early stages of heart failure. Okay? The picture that's shown here, this is actually a mural thrombus that you're seeing through a myocardial rupture. You can see the heart, and the heart is split right here because that wall was so thick, and you can see the mural thrombus underneath it. Questions? Last lecture. All right, you guys got my office hours for next week? If you have any questions, email me or come see me next week. I'll see you through the exam on Wednesday at 12:30 for the final.